Hello, everybody. I'm Duncan Turner, and you're listening to the Vagina Doctor podcast, episode 4. Get ready, because today this will be fun. We're talking to Dr. Jenn Kennedy, a master in clinical psychology and a PhD in clinical sexology. She's also a board-certified sex therapist. Please enjoy this. But what do I know? I'm just a vagina doctor. Welcome to episode 4 of the Vagina Doctor podcast. Today, we're privileged to have Jenn Kennedy with us. Jenn, if you look at her qualifications, she just really writes down licensed family and marriage counselor. But scratching a little bit under the surface, I see that she has a master's in clinical psychology and a PhD in clinical sexology. So I should be referring to you as Dr. Jenn Kennedy. Forgive me.
It's all good. Thank you.
Great to have you here. I'm looking forward to chatting about this. You by self-description of what you do, you're the chief sexologist and business mastermind in your practice at Riviera. And you oversee 6 clinicians doing pretty much what you're doing as well. And that alone makes you pretty remarkable for me, and that's a qualification that I've been looking for anybody that was on the program. Somebody who's very interesting and pretty remarkable. When I look at your website, I see there are certain areas of focus groups of generally looking at relationships, looking at difficulties that people have with transitions, addictions, mood disorders. But the one I really want to talk about is the sex and sexuality.
Me too.
That we're in the right place, because that's what my practice is about, or has morphed into. I used to be a regular OBGYN, and my practice has changed over the years. We don't need to go into the details of the bits and pieces, but now I find myself doing a lot of sexual medicine and making it physically possible for people to do that for one reason or another haven't been. So that's what I want to hear from you is how can we help these patients together, patients that may not have had sex for 10 years because of pain, usually, lack of hormones, lack of partner, or lack of intimacy in the marriage. And I look at basically the phases of a woman's life where this becomes more difficult, and things that they never worried about before, particularly the postpartum period for women, where it hurts, or they're tired, they're exhausted, they're destroyed, they don't feel very good about their bodies, or the postmenopausal patient, and then generally aging. That things aren't working. And then, of course, we've got to take into consideration the partner. And that's not actually quite as easy a lot of the time. So tell me about your practice. Tell me what you do.
Yeah. So I would say that the main clients that I see are in those same populations, because those are the pain points when people tend to come in and want more support. So I'm right there with you. My practice has morphed over time. I really got into this because I wanted to work with couples. I love couples. I've always been really curious about that. I did a lot of couples therapy myself and as a participant, and wanted to be on the other side. And so I started seeing couples right from the go and recognized that sex is part of that mix that gets missed a lot. There weren't a lot of resources. There wasn't a lot of information. And so I started researching and started going more towards that to help those couples. I mean, I see couples with general issues too, but I sort of look at this as a biopsychosocial. So people might come in through one door, they might think it's one thing, but I'm always like kind of watching for all of it, because the biological, which is probably more your zone, might be hormones, it might be blood pressure issues, it might be medication related, it might be something to do with their physical body not working properly. So I'm really careful to make sure that we understand what's happening on that thread, but then also the psychological, what's going on with their mood state. Are they depressed? Are they stressed out? Do they have trauma that they haven't resolved? Those kinds of things are going to get in the way of general life satisfaction, but certainly also of sex and sexuality. And then the social part is interpersonal. So that's the partner that you mentioned. And sometimes it can be happening on all fronts. Sometimes they come in thinking they just aren't that into their partner when really they've got trauma that's unresolved, and or they're stressed out, and or and so it's an unpacking, and it's a looking at the whole system. And sometimes I see individuals, oftentimes I see couples, both male and female, that are kind of looking to have a better sex life. So that's what I've morphed into, although I do some general mental health as well.
I would think everyone would have trauma that was unresolved.
You'd be surprised. Some people don't, but they're not going to be in my office more than those people don't come to therapy. And trauma looks like big T, little t. So trauma sometimes is going to be like an acute situation, maybe an assault, or in the sexuality realm, maybe it's like humiliation. Like the first time you tried to have sex was just really negative and it was embarrassing.
That's what I'm thinking of.
Yeah, and you feel weird about your body.
Yeah.
Or, those are like the little T's that sort of sit a little more covertly in the psyche. And so sometimes people aren't as aware of those and they're not bringing them in, but they're operating from that place of hesitation or reservation or avoidance. I see a lot of avoidance.
I think that the patients that I have the least success with, or let's say patients that I have less success with generally, I've been wanting another step to be able to take with those patients, or to put them in the right direction to deal with it. And it's, we deal with both men and women in my practice, hormonally and physically. We seem to have the things covered for the physical, for the body, and the hormonal aspects pretty straightforwardly for women. The men are a bit more difficult generally, in that we can, erectile dysfunction is a big issue, and we can be helpful with it. We've got hormonal therapy, we've got shockwave therapy, and we use topical exosomes, stem cell derivatives, all of which can help. But if it just doesn't work, none of those things seem to happen.
Well, the mind can also do a serious override.
Yeah,
like I see people
absolutely.
that start using, even Viagra, and then eventually their stress catches up, and even that will just their body won't respond.
Right.
There's a huge correlative with placebo in a lot of those medications. So the original cause usually starts to creep back in. And so if they don't address it, if it's interpersonal, a lot of times couples just really cave. They collapse when erectile dysfunction presents, and it's like game over, and they don't try to work through it. They don't treat it as just like okay, let's switch gears and try something else. They recede into shame and awkwardness and fear, and it's disappointing because it doesn't have to be that way at all.
And it's self-fulfilling also.
Yes, and then they're fearful that it's going to happen again.
Yeah.
So either they don't engage,
Right.
or when they do, there's so much pressure on the man, and sometimes it's just it's a self-fulfilling, and it's a deal breaker, and it breeds resentment and sadness and shame.
Yeah.
So what do you do with that type
Good.
of...
Exactly. That's exactly.
I
You
mean,
took the
because-
words out of my mouth.
Well,
Good.
because we're seeing a lot of it right now. A few cases of men that are, they seem to be doing great in every way but that. And what type of therapy or what kind?
First, I want to understand what's the cause, and if it's literally just like their blood pressure medication or anything that's on that, then it's like a decision tree. Okay, so if it's medical, then we just have to help them adapt to it regardless, right? Maybe they can try a different medication, but that's only going to go to a certain point. Maybe
Right.
what they need, what they're taking is what they need, and that's all they can take. So then it's a matter of, okay, what's option B? How can you have a sexual fulfilling life that doesn't maybe include an erection every time? You know, you still have sensation. You can still orgasm without an erection. It works.
I didn't know that.
Mhm.
Wow. Did you know that?
It's just,
Yes, I did know that.
I would hope you might know that. But I mean, there's this process you can do. It's called stuffing. It doesn't sound very hot, but you can actually stuff a flaccid penis into the vaginal canal, and it still has all the sensation. I don't know. I think it's more up here. It's more like,
Yeah.
you know,
Yeah.
it still feels good. And this is part of Pleasure Circle that I'm doing, is really trying to get people to think outside of penetrative sex, because there's lots of other options. And so if you take the pressure down, if you don't think that it's always about penis in vagina, and instead you can think, okay, what about erogenous zones? What about oral sex? What about digital penetration? Meaning digits. You know,
No, I don't know what you mean.
digits, like digital is like penetrating with your fingers
Oh, okay.
instead of
Got
with,
it.
with a penis.
Yeah, I know what that is.
Yeah. Yeah, there's lots of options outside. And so it sounds obvious, kind of, but like couples don't see it. And a lot of times it just feels like it's game over, and it's really not.
And is this bigger than, you know, this moment that this person comes to you? Should it go back to how sex and sex education is delivered at a young age to?
Oh yeah, they're not talking about this level. They're not talking about pleasure and satisfaction in sex education.
No.
They're talking about pregnancy.
Yeah, right.
Right. And most places, unfortunately, they're starting to even reduce sex education, which is a real bummer. But yeah, the pleasure part of it doesn't really get addressed in our culture.
And that's what the Pleasure Circle is all about.
Yeah.
6-week course.
Yep. It's a 6-week kind of intensive. So it's for women only at this point. And that's honestly because I cannot get men to come in with other men in a partnership type situation. Originally, my vision was to have couples, but the men have so much hesitation talking about any sort of sexual dysfunction in a group. So I made it about the women. And the women will talk. They'll talk with other women. So yeah,
Much more than men will talk with other men.
Yeah. And so each week we get together, and I'm right now it's limited to like 8 women. I'm keeping it small, so there's a lot of interaction. But basically we talk, I give a little mini lecture, like 20 minutes, about something specifically sexual related. And then I give them an exercise to do, some writing, some deepening, and then we talk about it. We unpack it. And it's pretty magical, actually. It's so much permission giving.
And then, so what do they do? Do they go home to their partners and say, how do they take what they've?
So, well, it's on Zoom, so they're already at home.
Okay.
But yeah, hopefully the idea is that they can take some of this information. I mean, initially I'm trying to really make them aware of all the factors that are affecting their sexuality. Then I'm starting to help them understand their own body and their own sexual, like erotic template is what I call it. So their own kind of sexual profile, what turns them on, what turns them off, how to increase that. And then understand in the context of the partnership how to show up differently and better. And so yeah, I imagine if they're taking it home, it's helpful because that's like a roadmap for their partner.
Yeah. Yeah, I think they would like that.
Yeah.
So.
Yeah, but it's really focused on her pleasure. So understanding her attachment style and how that factors into her sexual strategies. 1 week we look at toys and alternative ways of having sex outside of, you know, penile penetration. Yeah, so it's kind of a mix of things. It's a building up to like, this is where you've been, you know, what factors in for you specifically, and where do you want to go? What would you be willing to try? You know, how could you increase your own satisfaction?
Very, very interesting. But difficult because, I mean, we ran into this problem with the patients that, looking at the post-hormonal or postmenopausal or thereabouts patients, because that's the group that I'm generally involved with, not so much the postpartum patients at this point. That in 2016, we had this new technology coming across from Europe, which was the laser vaginal rejuvenation procedures with Mona Lisa Touch, and a bunch of other lasers came afterwards. I thought this was phenomenal. I thought it was great. The literature was good. I spoke to people that were using it, and they were impressed with the results. And there was a histological change that you could measure as to the effects of this within a few weeks. Got this equipment, and then I thought, well, how do we talk to patients about this? Because if I just ask a patient, how's your sex life, with, I'm maybe inappropriate, I may be prying in their opinion. So what we did, we changed our intake paperwork. And so along with the urinary frequency or nocturia or incontinence, we had, do you have pain with sex? Is that satisfactory? And that, just checking a box, was the easy way for them to do it, and it opened the door. I could start talking to them about it then. They didn't want to start it. I didn't want to start it and be misinterpreted without getting this check on the box.
Yeah. It's signaling right from the go that this is okay to talk about.
Yes.
And I think people are kind of like, they're hesitant. They feel some sheepishness about it, and they're not sure.
Right. Yeah.
They're not even sure what's normal and in terms of what's a reasonable expectation.
Right. And that really, it enabled us to be able to offer procedures to patients because we got them talking about it in a comfort zone.
Yeah.
But it comes down to the whole thing. We talk about, okay, why are we calling this podcast the Vagina Doctor podcast? And we thought about that quite a bit. There were lots of other options. And
why not the vulva? I miss the vulva. It never gets any attention.
Well, I'll get up to that in a moment. But my concern was when we tried to promote what we were doing in the media, we weren't allowed to. We couldn't say vagina on radio or talk about sex on the radio or on Facebook. It just wouldn't allow it.
Anytime I post anything that has even the word sex, it gets flagged.
Yeah,
it gets taken down.
Yeah.
I can't post masturbation. I can't post orgasm. All of it gets flagged and put to spam. I'm like,
I know. And when we try to do
outrageous.
Sexual health, can't do it.
You have to put an X where the E goes. That's what I found people do.
Okay, good to know.
That's how you get around some of the bots. Or when I do advertising and it gets rejected, I just hit secondary review and then they look at it again. But I'm like, wow, that just says something about our culture.
Absolutely.
Right? It's like there's this interest in sex and there's also this repression of sex.
And that's actually why we use the name Vagina Doctor, because my youngest son insulted me one day calling me just a vagina doctor. And we thought about that afterwards, and thought, this is what we need to do. This is going to stop people. It's going to make them listen. And we've already had responses from friends, and not so much family, but friends, that wanting us to say, oh, well, that's a great idea, but you don't want to call it Vagina Doctor. You want to call it
give it a nice
JJ
name
or something like that. And in fact, this is why I picked up on the vulva. Did I say something? No, I didn't say something.
No, I just know that nobody knows that they're actually referring to the vulva most of the time when they say vagina.
Or the other way around. It's so I just felt like there is another podcast that does come from Santa Barbara that's got somebody who's qualified in sex therapy, and her husband, who refer to it all as the vulva. And I'm saying, but that's not what you're talking about here. It's like they have themselves changed the or avoiding the name vagina. I mean, it just is so silly. But it's reality. But we're slowly getting through this. And hopefully I think this podcast should get some activity, if only because of the name. You know?
I'm going to listen for sure. I'm like, ooh, I love this topic.
Yeah. So
I want to just go back to in the questionnaire that we sent you. You talked a little bit about that you work with trauma patients via eye movement desensitization.
Desensitization.
Sorry, I don't have my glasses on. And reprocessing.
Yeah, EMDR.
So, there we are. Yeah, EMDR. What is that?
So it is a protocol that was originally developed for veterans. It's specifically to address trauma, and it's a bilateral stimulation that's done. The original way was following the fingers back and forth, so the eyes were following it. They've now advanced past that. Some people still do that. That's how I was originally trained. But there's also a light bar, or I use buzzers. And it's actually kind of fascinating. It works really well. And so it's a little bit hard to describe it, but the short of it is that a client comes in, say they've got an acute situation that happened, and it's an 8-phase protocol. And so you make sure they're resourced, make sure they're in a good place for that. But then what happens is it's exposure therapy. So we set up what we call a target of what happened, very briefly what happened, the feelings around it, and the level of distress. We take a measurement, and then we start this reprocessing. And the reprocessing really is about taking them to the situation over and over, but with calming. So there's breath work involved. The buzzers, I love the buzzers because they give a little bit of distraction, and they're sort of like hypnotic a bit, but it's calming the nervous system and kind of chunking it out while they're revisiting the disturbing memory. And then it starts to lower the distress. And so we're taking measurements along the way to see that happening. I mean, I can see it. There's an arc that happens.
Oh, wow.
But it's quite efficient. Insurance companies love it because it is so efficient. And they start to, it's not like they forget the memory, but they just don't care. They don't care in the same way. So it lowers the distress related to it. They can remember that it happened, but they just don't have the same attachment to it.
And are they hypnotized, or are they just like
they're not
sitting there with you, or laying down?
They're sitting there with me, eyes closed.
Okay.
I typically have eyes closed because it's easier to fall into the memory and to really kind of be in it. And the more you're in it, the more effective it is. It's gonna work faster and better. So it's pretty amazing, actually.
And how are they hooked up?
So I have these two little buzzers that they hold.
Okay, so they're holding, and that device is
they're buzzing back and forth fast, really fast.
Okay.
So the mind is kind of, and sometimes people also use a light bar, which is bouncing, and so their eyes are following it. And then again, the old school way is they would sit chair to chair this way and follow the fingers. So the bilateral is the key mechanism.
That's great.
Yeah.
I love that.
Bessel van der Kolk. I don't know if you know his name, but he's really been a champion of this. He's an MD out of Cambridge, I think, and he's really been doing this for a long time. He's an interesting guy, and he started it for just general trauma, but it's been really useful for all kinds of things. Yeah.
I was listening to Bill Maher's HBO Friday night show a couple of weeks ago, and he had a guest on this side called Esther Perel.
Mm-hmm. Yes.
And it was only a couple of days ago. I'm a couple of weeks behind on who was on it, and I was fascinated because he came out and saying all of the problems of the world right now I blame on the phone. It's the problem with the phone. And he said, but there's people having less sex now. There's less intimacy. There's why when we're so connected are we actually not connected? And she made a statement she said there has to be the sequence of events. There is attraction. There was an object, a obstacle, and there was desire that came as the third part of that. And it seemed to me that made a lot of sense, that if it is so easy to make that connection with somebody, there's no obstacle then the desire goes away. Is that sort of, what do you think about that?
Yeah.
And am I even quoting her correctly? Or?
Yeah, you're getting the gist of it. So it's interesting because as a couples therapist, I've always really appreciated her work. And then there's also Sue Johnson, who's sort of on a different side of things. And Esther is how you actually say it, I think.
Yeah.
She is more of the idea that fire needs oxygen, right? There needs to be a little bit of healthy tension in a relationship. There needs to be some missing and some distance and some mystery and novelty. I'm kind of in that camp. Sue Johnson is probably really, and sometimes I work this way too, but this is more for when there's a lot of trauma, is that you need to feel really known and super, super safe and lots of closeness. And once you know each other, then you'll feel safe enough. I kind of feel like I've seen both types of people, but I'm more of this camp of Esther's idea that, I mean, desire is not a static thing. It changes over the life cycle. It changes based on circumstances. As you have new information, new partners, new experiences, it shifts. Like your whole normal is different. And so I see a lot of long-term couples. I see a lot of couples also that are, or individuals who are 50s, 60s, 70s even. I have a few 70s. They aren't looking for the same thing. They aren't expecting to start over, but they want to reignite what's happening in their current partnership. They have a lot of respect for their partner. They have a lot of history with them. They don't have a lot of desire. And so that requires some work, some willingness, some playfulness, some risk.
Yeah.
Emotional risk. Yeah.
It's a strange subject.
Is it?
I don't know why you think it is.
Strange is not the right word, really. It's complex, very complex.
Yeah.
And so I appreciate having people like yourself trained and focusing on that. That's really beneficial.
Well, it's similar to vagina, sex. People don't talk about it, or they feel shame in talking about what they want or what makes them feel good or what turns them on.
Right.
They have such a hard time because they think they're going to make the other person feel bad. Or
the weird thing is like everybody is doing it, right? They're having sex, but they're not talking about it.
Yeah. No, I know.
How on earth
it's like everybody, that so many people do have a vagina and they can't mention it.
Yeah.
Right.
They can't. They don't understand it. I mean, they don't understand. I didn't understand it until I was about 30, and it came up in a very funny way. This is embarrassing, but I'm going to tell you the story. I was 30, and I remember having a conversation with someone and saying, like, I don't understand where the pee comes from. Like, I know it's not the same.
Yeah.
But I didn't understand, like, I just didn't understand the plumbing.
Yeah.
And I think the clitoris is another big mystery for men and women, but especially for men who are partnered with women. They don't understand where it is. They don't know what to do with it. They they kind of largely ignore it. And certainly in penetrative sex, they ignore it. So wake up.
Yeah. Or
wake up. That's the best.
Yeah.
Wake up.
Wake
All
up.
right.
I have a daughter and she's 19, and I've just come out and asked her, what is the sex like with your boyfriend? Mom. Like, what? I'm concerned. I'm curious. Like, and I want her to discuss it with me because I think she needs to know it's okay. Like, everyone has sex. What do you mean?
I think having those conversations, you're doing, and if you had a son, you should also have it with him. Pleasure matters. Her pleasure matters for sure, as does his. And it's typically easier for boys and men to get pleasure. Their plumbing is just easier for that purpose. But it's important for both partners to feel satisfaction, because the reality is that a lot of the women I see in the older couples, they come in saying they don't like sex, but really they don't like the quality of the sex they're having.
Right.
And so it's a rethink of like, what would you like? And if sex was, it's a feedback loop. If it was good, you'd probably want more of it, but you have to know what you like, and you have to help your partner understand, because it's not one size fits all at all.
Right.
Yeah.
Yeah, but I do think, again, it goes back to how people are educated early on about sex.
Mm-hmm.
And it should be more about pleasure.
Mm-hmm.
And yes, about getting pregnant and sexually transmitted diseases. But if it was more about pleasure, and also the trauma of everyone's first time of having sex and talking about that, because it is traumatic. I mean, for most women, I think, in my age group, it was traumatic. I mean,
Yeah.
not that they were raped or anything like that, but
Yeah,
it was
I
a whole
think
different
it's
thing.
just such a fumbling mess.
Mm-hmm.
Typically in the beginning, there isn't a lot of understanding, and it's such a loaded situation, even into their 20s and 30s. Like, they don't know how to ask for what they want, and so there's a lot of just taking what they get, and it's
And then they think that's the way it is,
right,
and they don't realize that it's 100% different than that.
yeah. Well, and one of the questions I ask people when they come in, which sounds always probably kind of confusing, is what's the function of sex for you? Because most of them are not in it to get pregnant.
Right.
They're in it for something else. And if you're in it to just maintain your relationship, that's one thing. That feels like a lot of obligation sometimes. And if that's your reason, then you're probably going to try to get it over as fast as you can. Is it playfulness? Is it exploration? Is it power dynamics? Is it, expression? And like what's it about? Because if you don't have a what, then you're not going to find a why, we've got to know what it is that you really are seeking, because then you're going to figure out how to make it happen more. But if you're just sort of like, I do it when I have to, then you're not going to want to.
Right.
Exactly.
Yeah.
Yeah.
And particularly if it hurts.
Yes. And pain is a big no. It just, it shuts down the system.
Yeah.
Yeah.
And I looked on your website, and you have things on there, like certain toys, or like the little dilator things that we sell at the office. And so if it does hurt, do you have them use?
Yeah, I love that dilator set. It's like a 10,
Mm-hmm.
kind of 10 sizes. And so I've definitely had women that they can probably actually accommodate a bigger size, but they're so shut down in their mind. But if they're doing self-exploration, they can start really small and feel much more confident. And they can, just be by themselves with lots of lube and music and candles and anything that's going to help, and just calm down and recognize that their body can actually accommodate it.
Yeah.
So I definitely use that, with women when they've got a lot of like a psychological holding.
Yeah.
around that.
We use those a fair amount. And as I say to patients, I say, look, you are in control of the dilator. Okay.
Yeah.
Not if the partner's there.
Yeah.
But you do. Okay. You can just explore with it
Yeah.
and see what you can manage, and have confidence that this is big enough.
Yeah.
It's just, it's you're going to get there.
I want to
So
talk
many
about
things.
your fun fact.
Yes. I don't even remember what I put down.
Sommelier.
Oh yeah. Yeah.
I love that. So go into that a little bit.
Okay, so I have never, it's funny, actually, I was adamant. Let me back up a second. I grew up in Idaho, which is rural, and most people there are really family oriented. And I never wanted kids, and I really never wanted to do the domestic life. And so I was really adamant about not learning to cook. Just dumb in retrospect, right? It's kind of important. But that was a way. I'm part of like a group of wonderful people who all love to cook, and we have gourmet dinner club is what we call it. But I don't want to cook. I don't know. I have a real aversion to cooking, but I like eating. So beverages were a place I could contribute. So I went towards the sommelier certification because it was really interesting. I like wine. I like to know about wine. It felt like a way, and I'm a mixologist. Like I make all kinds of fun cocktails, and I think that's really
wow.
it's a fun way to contribute without having to cook.
What's your go-to cocktail right now?
Aperol spritz.
Oh,
Okay.
Also, actually, Kettle One has a new botanical line that has.
Oh, I saw that.
That's like
Yeah.
they have a grapefruit one that's delicious with a little mint kind of mixer.
So if Duncan was not a physician, he would be a bartender. For sure.
Yeah, I was a bartender for a minute.
Yeah.
But I was like 30. I tried bartending.
Yeah, I did it when I was
The hours
in
were
my 20s.
terrible.
Yeah.
Couldn't
Yeah.
do it.
But he loves making cocktails, and he has this book, and he's always got it open and looking at
Reading,
his
exploring,
next.
and finding.
Yeah.
Yeah, it's fun.
Yeah, in the right glass. And
You know, what's interesting is that if people ask me what my hobbies are, you know, well, drinking.
Mixology. say mixology, it elevates
Yeah,
it.
it does sound better, doesn't
Right.
it? I'm a drinker.
Yes.
That's right. No, it's really
Viticulture, education.
Yeah, exactly.
Code.
Exactly. It's been fascinating.
But it
But
is
I've
just
learned a
as
lot recently.
yeah.
It's just
It's
Yeah.
as important as cooking, really.
yeah, it's really great. So
That's good.
yeah, we were lamenting the other day that we had gone to London over Thanksgiving, and there was one bar that we wanted to go to there, and we, for lots of reasons, we didn't manage to get to that. But we're making the point on the next trip to London, we'll definitely have to be there. So, you know, it's fascinating. I feel like I'm so much of a novice with it. You know, and just being able to tell the difference between certain brandies or whiskeys. Or I mean, yes, I can recognize it, but
Well, and this relates back to sex. I think everything relates to sex for me, actually. I can bring it all back. Is the sensory piece.
yes,
And I find that dropping into your senses with anything is going to enhance it. Certainly, like with wine, like I'm not always great about memorizing every, maker and region and that type of thing, but I can tell you the tasting notes. My nose knows what I'm smelling, so I can identify that. And I think in general, the mind really gets calm when senses are involved. Cooking is like this too, actually. It's gardening is like this as well. It's that process of tactile, but it's also sensory, smelling, seeing, tasting, all of it. The mind really likes that. And it wakes up and it sort of goes, "Ooh, this is fun. What is this? I like it."
right.
So back to sex and all the people we see in the office that maybe they're at about 50% that we're helping them. And what would you think, what would you say the perfect patient to send your way would be?
I would say couples or individuals, but I guess you guys aren't seeing couples because you're not.
We do see some
therapists, per
couples.
se.
Actually, we do see some couples.
Yeah,
for sure.
I would say typically it's going to be women who are feeling low desire.
Okay. And that maybe they've been treated with hormone replacement therapy, but not getting the benefit of increased libido.
Mm-hmm.
Okay.
Yeah, or it feels like it's a relational issue.
Yeah.
Where they're feeling like they don't know what they like. They've never had good sex. They feel ambivalent about sex. I see a lot of that.
And then do you think it would be appropriate on our intake forms to add a question about something?
I have scaling questions on my intake paperwork. I ask, how many times have you had sex in the last month? And how much did you like it? Like on a scale of 1 to 10. Like how happy are you with the frequency and with the quality of your sex life?
Yeah, I think those are good questions.
Because that gets at the core of the question, and it's just information. What's also interesting to me is when couples come in, the same people in the same relationship, and they quote very different amounts of sex. The men always say it's less, and the women always say it's more.
Oh yeah, I could totally see that.
And I'm like,
That
the truth
makes
is somewhere in
total
between. Yeah.
I mean, because one of the things that I love about our offices, I love helping people. And I tell people, we're results driven and we're not going to want you to throw a whole bunch of money at something that isn't going to work for you.
Yeah.
And then there's those times where it's not working. And I'm like, they got to go someplace else because this is either.
Yeah. I mean, it's interesting. Even with like the EMDR, sometimes people have blocking beliefs is what we call it. And it's like psychologically, they've got a hold that's preventing their body from allowance. Like they won't,
Right.
they can't. And I think that definitely probably happens in your work too. Sometimes there's secondary gains in keeping status quo. And so that might be, they don't want pregnancy. Like I find definitely sometimes when couples are trying to get pregnant, I realize that actually one of them doesn't really totally feel resolved about getting pregnant. And so it's interesting, like there's sometimes, or maybe
that's really interesting,
right. And it's hard to prove that, but it's like, I just see that there's a correlative that if there is unresolved, trauma or some sort of fear that may or may not be super conscious, then you're not going to let go of it because it's a coping strategy that you've developed that might be really intricate and quite creative, but you trying to just, rip that away isn't going to work. So that's why I feel like a little bit of an investigator sometimes where I'm like, let's unpack this and help me understand. Does it always happen? Has it historically always happened? Is there times when it's better? Like, is there something in this that you do like, or can you imagine, and that's why sometimes we just take it offline to self, and really understand your own self before you try to do it with a partner. Cause it's complicated. This is a complicated picture.
And then some patients are on a lot of medications, as they get older, they're all on all these things and they all have the side effect of, just decreased sensation or lack of libido. So you don't know what to do with those patients. I mean, it's because they have to be on that medication for whatever reason.
So I guess I would say I would help them reframe pleasure in general.
Going back to that.
Yep.
Right?
Looking at, so taking it off of like being so orgasm driven, like that's not the only measure of success. Like what else? Would you like a foot rub? Would you like oral sex? Would you like a nice deep makeout session? Like what else might feel nice for you? Maybe you just need a bubble bath with like a lot of conversation and a rom-com on the TV. I don't know.
Nice cocktail.
It's like, but giving them permission, because a lot of times too, I find that women, I'd say 50 plus, will tell me, I want more conversation. I want more connection. And I might want sex, but he goes too fast. So if I give him any sort of touch, he snaps and he's like, I'm ready. And she's not ready. So she'd rather not touch him, not involve herself because she doesn't want to commit to sex. So if it could be, if it could be a lower bar, I guess, and just allow for some connection first, I think that it would eventually lead to a lot more success.
Yeah, I like that. I really want to do something soon with you in the office and him for patients, some type of something. Because I feel like, or I feel like a lot of our patients would be really good for this type of therapy.
And for me, the difficult ones are the guys that just have erectile dysfunction that will not resolve with medication.
Yeah,
meaning
resolve. It won't resolve.
Well, I mean, it doesn't.
Is it caused by medication, or you're saying?
I meant was not resolved with Viagra or those sort of medications. that may in fact be caused by medication that they're on. But I'm not even sure of that being the issue. Those are the ones that are most difficult for me to solve the problem for.
Yeah.
So,
well, it's a loaded topic. I mean, I feel like in our culture, your masculinity is tied to that, and it's absurd because obviously their value is much more than just that. But there's a lot of shame. There's a lot of avoidance that ends up happening in the men I've seen in that population. And so if their partner can come around and say, I'm always like, hey, if it's not working, because this is, sometimes it works, sometimes it doesn't. When it doesn't work, what else could you try? What else might feel really good? Yeah. Like if you don't act like it's a big deal, likely his body will respond and get back online. Now, if they just absolutely cannot, and it's consistently, then they cannot, then that's a different strategy.
Right.
And what would that be? What strategy?
If they can't, if known that they can't have an erection. Well, and again, this might, it depends on what is their goal. I mean, if they want penetrative sex, they can wear a strap on.
Right.
Yeah. But a lot of men are like, I'm not going to do that. But it's like, why not?
Right.
They can still, like I said, they can still have sexual play. They can have oral sex. They can have, they have sensitivity. So there's a lot of pleasure to be had. It just doesn't look like maybe what it was in the past or, what mainstream shows. But I mean, our body is full of erogenous zones and lots of things feel really good. And most of it, honestly, is in the mind anyway.
Absolutely.
Right.
Turning you on is like in your mind. Yes, your body. I mean, but ultimately an orgasm is like, it's just a spasm. It's a muscle spasm.
Right.
Yeah.
And it's definitely all up here, what you're thinking about or what you're,
So, yeah, I think you can definitely still have a very satisfying sex life without an erection.
We were in Botswana last week. And I've been on safari a number of times, but I've actually never seen a lion's mate until this time. And it took about 3 seconds.
Yeah.
not even 3 seconds.
No foreplay whatsoever.
It was
no
like
foreplay.
boom, boom, and then they both lay down.
Yeah.
It was
they
crazy.
both collapsed on the ground.
I really couldn't even hit record on my phone. It was done. I mean, yeah. So it was funny.
Yeah, I think there's probably a fair amount of bedrooms in Montecito that's happening too.
Absolutely.
Classic.
It was really... Well, thank you. It's been educating.
Good.
Tremendous. Thank you very much for coming.
Thanks for having me. Yeah, I love that there's people that want to talk about this and have a have a frank conversation, and it feels
Yeah, it was great. We definitely want to have you back.
Thanks for listening, everybody. I hope you enjoyed the show. Please visit thepleasureproject.us for more information on Dr. Jenn Kennedy and the Pleasure Project. You can always DM the Vagina Doctor Instagram with any questions or topics you'd like to learn more about, or email us. See you in the next episode. The Vagina Doctor Podcast. It all starts here.